The NHI bill was passed by the National Assembly and will be sent to the NCOP before reaching the President's desk. It proposes universal health care for all, regardless of economic or employment status. It's been applauded as well as criticised, and there are many questions about the modalities and what users will likely encounter. We promised you answers to your questions, so we brought in Dr. Nicholas Crisp, the Deputy DG of the Health Department. Good evening to you and welcome, Dr. Crisp. I'm going to call you Nicholas for our interview. What is it? We have this recurring question since these developments happened. What does it mean for my pocket is a big one. Other countries fund it through taxes. They've got surcharges, special levies and contributions. Draw for us tonight a simple picture for what we can expect when it comes to individual payments.
Hi, man. You're welcome to call me Nicholas, and good evening to all of the viewers here this evening as well. So there's no one South African who has the same current position. So let's take a wealthy or a middle-class person and let's take a poor person. For the poor person, at the moment, they are dependent on the public sector for their care. Occasionally, they may raise funds out of their family or out of their savings to have a shorter queue in the private sector to go to see a general practitioner, but they will never manage to pay for healthcare in a private hospital. Those people are benefiting from a system that is stretched to beyond its capacity, where we spend about 5,200 Rand per person per year on about 85% of the population getting services there. So it is choked with patients, and the staff are extremely stretched, and it's very difficult to maintain and manage the services. For that person, they will get their health care still free of charge, like it is at the moment, except for those who do have a little bit of means. They will get their health care free of charge at the point of delivery once the NHI is implemented. But instead of being sent only to public sector facilities, public sector providers, the fund will send them also to nearer private sector providers who may have spare capacity. And we know that many private sector hospitals and other providers have a lot of spare capacity, up to 70% in some private hospitals. For the person who is middle class, maybe a little bit wealthier, who has a medical scheme, and there are about 9 million people in the country who benefit from some form of a medical scheme, it depends on the package they have and what they're currently benefiting from. So if you're someone like me who has a hospital plan, virtually only hospital inpatient care is paid for from my medical scheme. So everybody in my position would need to pay cash for general practitioners, dentists, laboratory investigations, x-rays, all care outside of a hospital, and even some inpatient hospital care, because we would only be covered really for the prescribed minimum benefits. And anything else beyond that, we would have to raise the money and pay for it out of pocket. So many people in that sort of middle bracket will find themselves with a medical scheme that does not pay for their benefits after June, July, and if they're lucky, maybe October or November, and then they're on their own and they pay cash until the next year. If you're very wealthy and you have the top packages, and you are amongst those couple of million people who insure yourself and are able to afford to pay for comprehensive care, you will get more of your care paid for from those insurance. But people don't realize those premiums can be above 30,000 Rand for a family per month. And that is way beyond what most people are able to afford. So what it'll mean for those people is once the NHI is implemented and as the benefits are taken over and covered by the fund, and I must stress this is a systematic process, not something that will happen next year or all at once. But once that point is reached and benefits are covered by the fund, then you don't need a medical scheme. In fact, the medical scheme will not be allowed to pay for those benefits. The fund will be paying for them. You too will go to the nearest facility, and most people who have medical aids live near private facilities anyway, and you will get your healthcare at point of care free of charge because you will have paid for it. And you're going to pay for it by increasing tax. That's what people are scared of. So the increase in tax is likely to be, in fact, it will definitely be less than you currently pay in your medical scheme's premium. because we know that maintaining 72 medical schemes with over 250 packages is an extremely expensive administrative burden, and that money can be saved. So we need to save on the duplication, we need to save on the way that we refer patients, and we need to get better access for everybody and not wait until you are so sick and end up on death's doorstep and suddenly don't have the money to pay for the care that you need.
So Nicholas, thanks for that, because I think it was a hard job to do, to synthesize it all across those categories and then make it understandable for us. So I think the one thing to ask is, would there be a table that kind of explains, on a scale of the type of patient, the type of care, and what the implication would be for them? Because I think that would be, hugely helpful to the public. But I want to go to this question out of what you've said. Will clients have a choice? Will patients have a choice about which hospital they want to go to and be treated in?
Okay, so we get asked, let me answer your question first, and I'll go to the other question I was asked. So in terms of with the table you're asking about, the bill talks about benefits, and there will be an advisory committee who's the final arbiter on what benefits are included or not included. This is a process that medical schemes are very familiar with, and for each package, they work out which benefits will be paid for or not paid for. This is a lot easier in a national health insurance because there's only one package for everybody. So what we are able to do is work out the numbers of people who are likely to require that benefit in a year. We call it the epidemiological profile, and we do some profiling of what is being currently provided for in the public service and in the private sector. And then those benefits multiplied by the number of people who are likely to be dependent on them, times the cost plus a margin for a profit or a surplus to be paid to the provider becomes the price. And once we understand what we can afford within the budget that is provided to the fund, and obviously it will start small and it will grow over time, we can then include in what you refer to as a table of benefits and make it public. And the trick is to make it very public. It must be available to everybody, and every single person must know that you get the same benefits as the next person because you need that care, not because you've got money or you're of a different gender or race or something or socioeconomic group. So that's the answer to the first question. It's obviously more complicated in its finer detail, but that's the principle. Regarding choice, what the bill says is that everybody, all 61 million of us who live in this country, should choose our primary point of first care, and that's in primary health care, where we will go and register. So I will go to the GP down the road because that's the nearest healthcare provider to me. It's a private GP to where I live. But if I'm living in an area where there isn't a private GP and there is a public clinic, I will go to the public clinic and I will register at that point. Registration is very quick, very easy. It just means you open the file once and you never have to open it again, because that number will be available to you anywhere you go in the country, whether it's a public or private provider, provided they have been accredited by the fund and therefore going to be paid by the fund. And that will take time to achieve as well. Now, you have chosen that point of care because it's close to your home, and you know you're going to be able to access it on a regular basis for your normal minor ailments and care that you need. When you need anything beyond that care, that person who looks after you, as I say, whether it's a public clinic, an NGO clinic, whether it's a private GP, that primary healthcare provider will refer you to the level of care that they are not able to provide. And that's in the benefits package we spoke about a moment ago. You will be able to see that up to this point, this provider is able to look after me. And if I need anything more complicated, sophisticated diagnostics or care, that practitioner who looks after me will send me somewhere. Now, in order to send me somewhere, we need to give those primary providers options, and that's the referral network. So it may be that there are 4 or 5 hospitals within striking distance, but only one has got a cardiac cath lab. So if you have problems with your heart, you will be sent to that cardiac cath lab. If you have family that are able to look after you in another place, if you have better care environment closer to a different facility, those are the rules we need to write that will say you need to inform your primary provider who will make the arrangements for you. And they will do so based on bed availability, clinician availability, and the sophistication of the care at that point. So there is a lot of choice, but not entirely choice for everything.
All right, thanks for those explanations so far, Nicholas. So on the line, we've got Jack from Pinetown. Jack, good evening. Please feel free to pose your question, and welcome.
Good evening, good evening. That's very nice. I'm hearing this NHI, but think about what's happening at the moment to the sick people when they're going for attendance at the hospital. They go to 12 o'clock in the night and stand in the queue till morning. I think that's the main thing we should get sorted out. Have the facilities to provide service. I mean, let's dream about getting admitted to hospital. The moment to get treatment at the hospital is the problem. Every hospital you go, you got a problem. People, elderly people going 4 o'clock, 3 o'clock in the morning and standing in the queue for medication.
Yeah,
it's beyond my thinking about one day. So why can't they solve the problem out first? Have the facility to take care of the people. Then you can go to NHI and sort something out.
all right. Thanks, Jack, for that. Nicholas, how would you respond to Jack?
In the private sector, we could solve a lot of problems. The private sector is spending 27,000 Rand per person per year. The public sector is spending 5,200 Rand per year. And every year, the public health budget is cut, not increased, but every year the private benefits, tariffs that you pay is increasing. So there's more and more money being made available, albeit our private money, in the private sector, and less money in the public sector. And as we know, we have now got to absorb over 7% increase in remuneration of wages within the existing budget this year. So frankly, it is unlikely that the public sector is going to be able to do much to shorten the queues and so forth. However, there are ways in which we can improve our lot. The one way is to use the primary health care facilities, the clinics and the health centers, for all common ailments, and to not go and sit in hospital queues. The other way, which is used more and more widely, is for the doctors and others who are looking after you within hospital outpatient departments to refer you to the chronic diseases medicine distribution mechanism. We call it the CCMDD, where you can collect your medicines at peripheral points, not even only health facilities, but a whole variety of other places. The CCMD, we call them PUPs or pickup points. So we are trying to help decongest outpatient departments by moving more and more chronic medication into communities where you don't have to go every time for collecting your chronic medication.
But just one quick word. I've got Cupido from Cape Town holding on, but I just want to quickly ask this. Talk to us in Jack's experience. I have an emergency now. I'm going to go to the place that's closest to me. It's dysfunctional as it is right now. How is it magically going to change if the NHI comes into being?
Yeah, so I gather Jack is in Pinetown. I'm not so familiar with the geography there. So let me use a different example and depersonalize it from Jack in Pinetown. Let's take an example in Gauteng of the community of Diepsloot. That community is dependent and has to get their hospital care at either Charlotte Macheche or at Tembisa Hospital. Now, those hospitals are extremely inaccessible across highways, even at the best of times. And during traffic, it takes long to get there. But they have to drive past several private hospitals to get to those hospitals. So what the NHI will do, and I would actually quite like to do it now if we had the budget to be able to do it, and we will try to experiment with it, is why can't the public sector, the fund, purchase healthcare for the people of Diepsloot from the nearest private hospital? It's only 11 minutes away.
Wow.
And if at the moment that hospital is not fully occupied, the one that happens to be the nearest, there are two more hospitals, private hospitals, that are both closer to the community of Diepsloot than either Charlotte Macheche or Tembisa. So what we need to do is agree on a price that we will pay for that care. And the fund will pay for that person, just as it will pay for a wealthier person who lives on the doorstep of that private hospital. And the patients will get their care without having to travel to long queues in congested public hospitals.
Okay. Okay, that was really simple to understand, Nicholas. Thanks. Cupido from Cape Town. Good evening and welcome to Full View. I don't think that he is still there. All right, let's go then to our next caller. And Tiny, good evening to you and welcome. Tiny, are you there?
Yes, ma'am, I'm here.
Please go ahead. You have the floor.
Come again?
You may ask your question, Tiny. Welcome.
Yes, thank you. Yeah. Apparently, I'm sick, from what's called. My PSA was high when I went to the public clinic, and I was referred to the urologist in Baragwanath. And because of my PSA was high for the prostate, and then I went for the biopsy at Bara. And then I went for the biopsy at Bara, and I'm still attending. I'll be attending again for, they said on the 14th. I'm on cassette now. And apparently...
We've lost Tiny there, unfortunately, Nicholas. And I'm not sure if it was a question related more to his diagnosis and his prognosis and ongoing treatment, or whether it was related to the different facilities that he has to visit in order to receive this comprehensive care. But hopefully we'll get him back and he can clarify. Up next, I think we have Martin. Good evening.
Good evening, how are you, ma'am?
I'm good, and you?
Yeah, I'm good, man. I just want to ask how will the government manage to do this while they are unable to run their public hospital now? I mean, if you go to different hospitals, they are running short of medication. Clinics, we are no longer talking anymore. I just want to know, how are they going to do it?
Thanks, Martin. Nicholas?
Thank you very much.
Yeah, thanks very much. Thanks, Martin. Thanks, Iman. Look, that's a fair question, and it's the answer. I'll try and simplify a very complicated answer. So at the moment, the public sector hospitals are run by the provincial administrations, and they get their budgets not from the National Department of Health, but from the provincial government. It's what we call a provincial equitable share, which is given to them from the National Treasury for the whole province for all their functions. Those monies are then allocated to health and security services and a variety of other functions that the provinces are responsible for. So they get insufficient funds to be able to deliver the increasing amounts of care, especially in big facilities like Bara, where Gauteng's population is growing rapidly, and there are more and more people making demands on these facilities. So it's now become a vicious cycle. The infrastructure has been eroded, and the number of patients who are dependent on a depleted number of personnel and so on, it really is a vicious cycle. We concede that a large part of the problem has been managerial problems, and there have been unfortunate and very embarrassing issues of theft and fraud and so on. Don't for a moment think the private sector doesn't experience theft and fraud as well. It happens everywhere, and it's an unfortunate part of our society we need to deal with. But what the National Health Insurance Bill does is it removes the function of the actual delivery of healthcare from the province, the assigned function, and centralizes the budget for all the healthcare, all the personal healthcare, into one fund outside of the government, but within a government agency. And then the provinces will be the providers of healthcare. But if they don't actually provide the healthcare, the fund will not pay them for any healthcare they don't provide. So there's a massive shakeup, which again won't happen overnight, and there need to be new management mechanisms put in place and new structures of how payment happens. And by making this a national program, a number of things happen. One, we get better procurement pricing and certainty in the products that we buy. Two, we don't have the boundaries between provinces, which mean provinces, people who live on boundaries and cross into other provinces are sometimes, if you like, victimized or turned away from services. and we are able to be more direct in the way we deal with management failures and so forth from a national process.
Yeah.
This is not unique to South Africa, but that everyone thinks it's just about the private sector, but it's not. So there are lots and lots of management strengthening and reforms that are also described in the National Health Insurance Bill.
Yeah, this is where I think a lot of people sort of raise their eyebrows, you know, to say that if government or the structures that do exist can't manage little, how are they going to manage so much in taking care of everyone in South Africa when we see the parlous state of health and infrastructure in the public sector? I'm going to just quickly take a breath on that note, and I've got Jeanette from Soweto and Mike from Rustenburg. We'll take them together. Jeanette, good evening and welcome to Full View.
Good evening, ma'am.
Go ahead, please.
Hello?
Hi, Jeanette. You are more than welcome to go ahead and ask your question.
Yes, my first question is, I hear the gentleman who's talking that he's talking about the distance of the hospital that people must go to. And we've got people who are very, very poor, who can't travel that distance. Secondly, right now, as we speak, everything that is happening here, we found that they are catering for black people, I'm sorry, not for black people, for foreigners. We as South Africans, we are not getting any better treatment here in South Africa. Even the people who are paying tax, they are struggling to get a better service here in South Africa. Now there's this new thing that is happening right now. Who is going to assist all these people who are suffering to get a better treatment here in South Africa?
Janet, thanks for the question. I've noted it. Martin, yours as well, and then we'll put these to Nicholas. Go ahead, Martin. Or is it Mike? Sorry, Mike in Rustenburg. Go ahead, Mike.
Yes, it's Mike speaking, ma'am. Hello.
You're more than welcome, Mike. I can hear you. Go ahead and ask your question.
Yes, I would like to know what happens with those people who already belong to a medical organization like e.g. I belong to GEMS. How will this NHI affect me?
All right. Thanks, Mike. Nicholas.
Okay, thanks. Three different questions, and thanks to Jeanette. Yeah, so the problem of the long distances is a particular challenge for people mostly in rural areas. But even in some urban areas, there are people who have to travel fairly long distances purely because they have to drive past other facilities. Now, there's a requirement of the National Health Insurance Bill that over time, the fund must provide incentives for other providers to deliver services in areas where there's what we call unmet needs. So if you are in an area where there is a need for services, large need for services, and it's not being filled, the fund has to create mechanisms to pay providers, so for instance, GPs or people who establish clinics, some form of incentive to set up care in those environments. So we call it strategic purchasing, and there are a variety of ways in which we can do this. There are other ways, and that is to move the patient. So for instance, if you live in vast areas like in the Northern Cape, you can't have a hospital in every small place, so you have to move the patients to where we are able to have sufficient health professionals living in one place. So there are two ways to do it. One is to provide incentives for providers to increase their services in an area, and the other one is to recognize it's not going to be possible and to improve the transport mechanisms. And those are all requirements in the bill for the fund to attend to. It won't happen in a very short space of time, and we are acutely aware of that problem. The second question is about foreigners. There are a lot of foreigners in South Africa, but don't for a minute think that they don't contribute to the economy. And most of the foreigners in South Africa are in fact legally here. There are foreigners who are illegally here. And what we do is we have international agreements, which South Africa is signatory to, that requires us to look after and not victimize people and to make sure that they get the health care that we have signed in those agreements. So there are different kinds of foreigners. There are people who are here as asylum seekers, getting away from war or other economic chaos. There are people who are refugees from either being persecuted or otherwise. And there are people who are legal immigrants who have come to live and work in our country from many other countries. And then there are some who are illegal. And what the bill does is it says we will look after people according to the agreements we have made in the international space. So those who are legally here, asylum seekers and foreign refugees, bona fide refugees and so on, we will look after them. And we will look after all children because that's what civilized nations do. And for those who are in emergency conditions, we will look after their emergency and then they will have to be repatriated to where they go.
Yeah.
So that is a program between the various departments of government. But I would ask that as citizens of this country, we look after those who are around us and we work together to make sure that people never have to suffer because of their ill health. Many South Africans have benefited from healthcare in other countries during the times of apartheid, and lest we forget that we need to look after one another.
I'm completely out of time. So if we can, Nicholas, I don't know if you can do a 20-second answer about what happens to me on medical aid.
20 seconds on medical aids. Once the fund is covering the benefits that you currently pay your medical aid to cover, you do not need the medical aid to cover that anymore. Then the fund will be paying for it. So the fund will replace the functions of most of what you are currently being covered in your medical aid. And that's all I can say in 20 seconds.
Thank you, and perfectly timed and orchestrated. Dr. Nicholas Crisp, we appreciate you. That's the DDG from the Department of Health.